All right, it's 18 minutes after the hour of 7 o'clock. Welcome back to the No Morning Show here on TTT. I am Natalie Lagore, and on Zoom with us this morning is Dr. Ravi Lalla, Medical Chief of Staff at the Arima General Hospital. And he's just here to talk to us about, what happens to that COVID-19 positive patient who is hospitalized and how the doctors even manage. Good morning to you, Dr. Lalla.
Morning.
And how are you doing?
I'm tired.
I would imagine
but
so,
doing well.
honestly. But when you're a doc on the field treating with COVID positive patients, what are the hours that you work?
Long hours. It's not the kind of job that you could just clock in and clock out of.
Yeah.
Obviously, even if you have hours of work, people routinely work many hours past that and will pull 70-hour weeks easily and longer. I work 7 days a week and I basically never stop working. And my team
Wow. But talk to us, Doc, because this morning we had Dr. Rambachan on the program just sharing his experience of being COVID positive with us, but he was still able to be at home. What is different for that patient who is hospitalized? What are the different symptoms? Or talk to us about at what point do you all decide that this patient should be hospitalized?
Right. As you know, the way COVID could present is an entire spectrum of disease. And as you're saying, it could be asymptomatic, it could be relatively well and stay at home. But basically for us, if somebody becomes oxygen dependent, we bring them into hospital. And there are some numbers for oxygen saturations that we use and whatnot. But even those things, while they're kind of empirical criteria, what we end up doing is if somebody is not able to manage themselves at home, then we bring in.
Yeah. But, in terms of, looking at the numbers and stuff, is it that, you have patients, all of them, the numbers are same, all of them react the same, are treated the same? Talk to us, because we hear all the time that you may have somebody who's asymptomatic, so I think that there are tiers to how people may be affected by this COVID-19.
Yeah.
So talk to us about those patients who are all of them oxygen dependent?
No. So the patients that are in run a wide gamut. There are obviously those that are oxygen dependent and they run the spectrum from nasal cannula to a face mask to being in ICU. And then you have other patients who have COVID, but they also have other comorbidities. So for instance, if I have a cardiac condition and my cardiac condition is preventing me from going home, but I still have COVID, then I also need to stay. So there's a significant amount of patients like that, patients who may have end-stage kidney disease and they need frequent dialysis, for an example. Those types of patients might not be feasible to send home, and definitely we would need to dialyze them in a space that takes COVID positive patients. So so those are the kinds of patients that you would have in a hospital. There are also patients that would be in a what we call a step-down facility, who would be relatively well, but they're not able to isolate at home or take care of themselves at home. Say they may have a mobility issue, or the way their home is set up is not ideal for isolation from the rest of their family. So
actually, Rockus, Carrie and I were speaking about that earlier, that, sometimes we understand that some people, the idea of isolation is impossible just because of the size of their homes and the amount of people in them. So that's what the step-down facilities is used for those kinds of people.
Yes.
You see, and I always thought that it was just the patients who were hospitalized, getting a little bit better, go to the step-down facility before going home.
Well, so what we conceptualized is a sort of ecosystem of, as you were saying, tiers of care.
Yeah.
And so there are step-down facilities that would be looking after those patients who just can't isolate. And then we have augmented step-down facilities where there's a little bit more care. There would be ability to do oxygenation. You have more intensive interventions that you could do. And then you move up the spectrum of types of hospitals until you're at a tertiary level hospital within
Right.
the parallel healthcare system.
And, especially in this last, I would say 2 months, what are the chances of death for that patient who is in that tertiary care hospital?
Hmm. That's difficult to say. Somebody who is in the ICU now, all over the world, ICU mortality rates tend to be on the higher side. More importantly than the actual raw statistics would be the heuristic of dealing with patients like that. Meaning, our idea is that we want everybody to have a Christmas with the family. We want to send everybody home. Right. So whatever it takes, we have consultants in our ICU here at Arima who work 24/7. They are on site 24 hours a day, 7 days a week. And we make constant decisions on our patients. So and mortality rate here has been pretty good. So most of our patients leave. Most of our patients, by the vast majority of our patients, leave and will go home and do Christmas.
Well, I'm definitely happy to hear that. But in terms of the patient themselves, do we ever know when somebody contracts COVID, who is going to end up in the ICU?
No, I mean, earlier on, and this still holds true to some degree, you would have the patients who are a bit older, have comorbidities and whatnot. And so we know about those. But also now in this new wave we have also younger patients. It's a little bit difficult to, like right now in our ICU, we have someone who is 40-something years old. Yeah,
wow. So is that you just, I mean, while there might be a trend, is that we are seeing other people who are ending up in ICU without the comorbidities, without the being elderly, so to speak, or being aged.
Yeah, and even people who are young. So sometimes you will have 20-something year olds playing football, etc. before, and they get COVID, and even if they don't make it all the way to ICU, they still, when they come out from the illness, they still have a significant amount of limitation in how much they could run, and it takes them a long time to get back to where they were.
Talk to us about that, Doc, about long COVID, because we're hearing about it. We're hearing that there are people who suffer from long COVID. What is this long COVID?
Yeah, the terminology just really applies to, you had COVID, you got over COVID.
So you're testing negative now.
You're testing negative via swabs, etc.
But you're still having symptoms.
You're still symptomatic, and not really symptoms of active infection, but you have limitations to your physical activity, etc. That's actually what you may have heard about our executive wellness clinic, or the long COVID clinic that we have here, that we started here at Arima. And that was around that. Early on, in the pandemic, you would have seen a lot of papers come out about, before long COVID was even a thing, and a term, that people just were having a lot of symptomatology after they got better. And so the team then conceptualized an idea about having multiple specialists see someone in one day with multiple different types of testing to try and risk assess them. So we had like a nephrologist, a cardiologist, etc., a pulmonologist, and through that clinic, we've seen a wide gamut of patients, young, elderly, but the aim of the clinic is to try and improve people's lives.
Right. So after they've suffered these symptoms, so when they come to the clinic with the symptomology of long COVID, how do you treat them? What do you do?
Right. Well, the idea of the clinic was to just recognize the different facets that having COVID would have upon your life. So, for instance, while being doctors, we oftentimes talk about organ dysfunction and whatnot, But one of the things we recognized pretty early on as well is that there was a psychological as well as a social impact to having COVID. You know, people had issues with the job. There was a significant amount of depression associated with quarantining and the isolation and whatnot. So in the clinic, we decided that we wanted to try and address as much of these things as possible at that time, and then set up follow-ups for the facets that the person needed the most amount of attention upon. So if somebody comes to our clinic, how our clinic is set up is their circuits, because we didn't want the clinic to go on for too long, because we know after a certain amount of hours, people would want to leave. But so people come into circuits and they get plugged into the different parts of the circuit where they will see either a psychologist, a social worker, get maybe a CT of the chest, get an echocardiogram to look at their heart, see the different specialists associated with those systems.
So whatever symptoms they're having or whatever issues they're having, the clinic is there to support that.
Yes, as well as the clinic is there to look for things that they may not have even considered having. So the first time you come, you get to see everybody as we look. And then after that, we then see where your issues are as we continue.
Right. Well, I'm definitely happy that that kind of support is there, at least at the Arima General Hospital, for those who suffer from the symptoms of long COVID. But Doc, I want to go back to that hospitalized patient, because I'm thinking that because we don't know what happened in the hospitals, we believe everybody and everything is hunky-dory and everybody is fine. Talk to us about that patient, patient A, patient B, and what, you know, the routine is like for that patient, what he or she has to go through, especially if he or she is in a tertiary hospital.
Right. Well, I mean, the first thing I think that any patient would kind of encounter is being away from the family. I know I had to quarantine after I was exposed at once, and just quarantining for me, even though I know it's right, is difficult, but you have to do it, you know. And so I can imagine that the first thing that would happen to somebody is that they would kind of feel a little bit isolated. So, but what we try to do is make sure, of course, that patients have communication with the family. We have internet, you have your phone, you can make the calls.
Doc, hold that point for me. We're going to take a very short break. We'll be back. Just stay right there. All right, we are back. We're speaking with Dr. Ravi Lalla, who is the medical chief of staff at the Arima General Hospital. And Doc, you were just about to tell us about that patient who you say may feel isolated being in a tertiary hospital. You know, so you were talking to us about what you can do to help with that.
Right. So we have ways for people to have entertainment, internet, etc. The other thing that we provide every day to our patients would be social workers and psychologists who interface with our patients, and first just to speak, to talk, and if anybody have any specific issues, to then escalate what we would be doing with them. From a medical perspective, what's happening by us is you will have multiple ward rounds happening daily by consultants. My ward consultants work in shifts to cover as much of the 24-hour cycle as possible, so that we make decision points multiple times throughout the day to try and, you know, hone decision making towards any particular patient.
So is it that a patient can deteriorate? So let's say the rounds are done at 7:33 a.m. and the next round is at 10, and the patient could deteriorate in that time frame?
Yeah, patients could deteriorate at any time. So one of the things that we've done to try and mitigate that is we always have doctors in the hot zone. So despite rounds being a kind of formalized process where people move through with consultants and registrars and make decisions, even outside of that cycle, there's constant cycling with doctors always checking at all times. So anytime you go into our hot zones with our patients, you'll find clinicians there.
And do we have a lot of instances of that where patients, you know, the stability they just deteriorate? And what causes that with COVID, where a patient could be here, you know, maintaining an oxygen level of, let's say, 95, and then it just drops to 80, and then you know, the doctors might have to be thinking maybe this is somebody for ICU.
Mm-hmm. Well, remember, with COVID, we have the clotting issues that some people speak about, the clot in the lung. So that's always a possibility, and that's something that could happen very suddenly. Failing that, what we do as well is we have a type of scoring system that we do on every patient multiple times a day, something called a News2 score. It's an illness score. And the higher you score on that range, the more often you have to check back the score. And so those are things that we do to try and mitigate that scenario that you're talking about, someone just suddenly decompensating.
Right. And yet we're still seeing patients dying, doc. What's the underlying cause for these deaths?
Yeah. So you would have events that might not really be due to COVID. So for instance, as I was speaking about earlier, a lot of patients with COVID have other issues happening. So say a cardiac event. A cardiac event is an independent event. Somebody doesn't necessarily need to have ongoing chest pain to have a massive cardiac event. So you would have people who have things like that, one-off events that just could happen. And remember, COVID itself is, you have an ongoing disease process which has its own inflammatory system happening. There are a lot of inflammatory markers associated with COVID, and those things tend to precipitate other events that would not necessarily have happened had you not have this inflammatory process going on.
So are we seeing the COVID causing, you know, other comorbidities to be enhanced and to cause people, you know, more distress? Is that what's really happening?
Yeah, I think so. And besides just the straight A to B of COVID causing something, COVID itself has caused a lot of differences in how people even manage their chronic illnesses. Yeah. So, you know, a lot of people may not be going out as much to get the medication and et cetera, et cetera. And all of those things now mean that patients who would have something now have a higher tendency towards decompensation from that pre-existing illness. And so it's you know, it's a whole system of things that's happening.
Mm-hmm. Yeah, so, well, Doc, what do you say to the people out there who are saying, who want to lyme still, who want to break curfew, who want to just go about their jolly business? What do you say to them?
I would say to them a few things. People conceptualize healthcare as a building that is somewhere and you go there for healthcare. And I want people to understand that healthcare is really us, the population. It's a partnership between a physical space and our practices. And no matter how strong you feel, the fact is you can get COVID easily, and you don't know if you would be that person who could be young and strong and end up in ICU. And worse yet, you don't know if you could be that person who remains young and strong, but gives the COVID to someone that you care about, and that person ends up in ICU. So I really want to implore everybody to follow the guidelines. It's not rhetoric. It's not meant to impede on somebody's freedom or anything like that. It's really for our safety as a people to move forward. Yeah.
Right. And vaccination?
Vaccinate. Take the vaccine that's available. Take it. There's no debate to be had about if you take the vaccine, if you get a blood clot. The numbers, the percentage of people who would have the blood clots from a vaccine is 0.01 or some very low number. The percentage of people who get a clot from COVID is 16 point something percent. The number is not even close. There's nothing to there's no comparison. Vaccinate.
All right, Dr. Lalla, I want to thank you so much for sharing with us this morning, and continue to stay safe and do the work that you all are doing.
You too. Thank you so much.
You're most welcome. Dr. Ravi Lalla, their Medical Chief of Staff at the Arima General Hospital, just talking to us about what the COVID experience is like. And I don't know, I mean, it sounds like the doctors are doing all that they can to save lives, but I don't know that I want to find myself in that position so that you have to save my life. It means that I'm already battling. All right, we take a break and we'll be back with you.